Welcome, everyone, to our Neuroendocrine Tumor Research Foundation virtual meeting, Treatment Sequencing Tumor Board. My co-moderator here is Thor Halfdanarson from the Mayo Clinic, who is a medical oncologist, and then our outstanding panelists are Heloisa Soares, who is a medical oncologist at the University of Utah, Courtney, Lawhn, Heath, who is a nuclear medicine physician at UCSF, Andy Liao, who is a medical oncologist at the University of Chicago, and then Ahmed, who is an interventional radiologist at the University of Chicago as well. We're very excited to share these two cases with you. The way this is working is that I will present the first case, and then Thor will present the second case. So welcome, everyone. All right, let's jump straight into this. This is case number one. It's a 65-year-old female who presents to an outside physician with flushing, diarrhea, and cramping after eating. A CT scan was performed at this outside hospital, and it's found first a non-contrast CT is seen here, and then later on a CT with IV contrast. And there are two things that are found on this CT. But the first CT, non-contrast CT, shows that there are some lymph nodes here around the mesenteric vessels, so the vessels that supply your small bowel and your large bowel with blood. Some lymph nodes that appear to be enlarged here. And then there's this lesion in the liver on the right-hand side on the CT with contrast that is sort of suspicious and should not belong there, although the read was that it is unclear what this actually could be. So the outside hospital referred this patient to an oncologist who recommended a biopsy, and it was found to be a well-differentiated neuroendocrine tumor, low grade. The Ki-67 was less than 3%, and it was a stage 4 disease because the biopsy was of the liver, and the tumor is expected to have started somewhere in the small intestine and has spread to the liver. Now, additional tests made by the outside medical oncologist were urinary 5-HIAA, which is a tumor marker that we check for in patients that have symptoms such as flushing and diarrhea, and that was positive, and a chromogranin A, which was quite high as well. So this is the dotatate PET-CT that was ordered by the outside medical oncologist. Courtney, can you give us a quick read on this? Is there anything in particular that looks suspicious to you?
Absolutely. I'm happy to talk about this image. So this image is going from we see from the top of the liver down through the pelvis, basically the area that was being shown on that prior CT. And in kind of the right lower quadrant area where we saw that mesenteric lymph node that was being pointed to, exactly, thank you, we do see uptake in that lesion. And so that is very suggestive and very consistent with the biopsy-proven, well-differentiated neuroendocrine tumor in the liver. In addition, if you look in the liver, which is that gray triangle in the right upper quadrant, there's not one just abnormal polka dot in there. Unfortunately, there are many more than the CT seemed to originally suggest. Including the one, presumably the one that was biopsied. So it looks like there are multiple liver metastases in this patient, in addition to that mesenteric lymph node metastasis.
Thank you very much. So the patient was started by his outside oncologist on octreotide. Heloisa, is that the first move you would do in those patients generally?
Yeah, well, I do think, first of all, the patient should be discussed on a multidisciplinary setting, just to make sure that we all agree what's the best strategy. But in this case, my personal take would be to consider a somatostatin analog, the initial approach. We do have now, many centers have actually a clinical trial that we could consider in comparing two different or somatostatin analogs that we could have offer to this patient as well, outside of standard of care, use of somatostatin analogs, either with octreotide or lanreotide. And I am okay with that. I think there's a few other things that I would like to do, but you might be discussing that.
Yeah, let's jump on that a little bit later. So the patient was started on sandostatin monthly, had some improvement in flushing and diarrhea. Although she did, complain of some mild persistent cramping after eating. The outside medical oncologist kept an eye on the tumor burden with CT scans every 6 to 12 months. Now, a year and a half passes, and the patient now presents to again, an outside emergency department with shortness of breath, fatigue, as well as vomiting. The CT scan is done again with IV contrast, and this time this shows. Andy, if you get consulted down in a patient with down from the ED to go down to the ED to look at a patient in a CT like this, is this something that worries you as a medical oncologist?
Yeah, I worry with where the mesenteric lymph node is causing some obstruction symptoms.
Yeah, I would agree. And actually, the general surgery service was consulted as well at this outside hospital, and the patient underwent an emergent operation for what was thought to be compromised bowel, which you can see here, the swollen sort of, wheel-shaped bowel here that's much thicker than the normal bowel here on the right-hand side. And so a bowel resection was performed at the outside hospital, and the pathology showed a 2-centimeter well-differentiated neuroendocrine tumor with 1 out of 2 positive lymph nodes. Thor, is this worrisome to you, that pathology report, highlighting the 1 out of 2 positive lymph nodes? Is this something that you care about, meaning does it matter how many lymph nodes people remove?
Well, for metastatic disease at this point, probably not. If this was someone who did not have metastases, I'd be a little worried about only getting or retrieving 2 lymph nodes in the entire specimen. One wonders, did you sample enough lymph nodes? Was it adequate resection? This is coming from the medical oncologist, not the surgeon. But in this particular patient, it wouldn't worry me particularly.
Okay, great.
Yeah, and then this is, I think that's the difference between when we have a planned resection versus something that was done in the emergency setting, right? This is a patient, when we were talking about things that we should have considered, is whether or not we should have discussed the resection of the tumor when the cramping was not going away. Was the cramping related to the local disease? And if so, that's when having a resection of the tumor in an elective setting will have the ideal situation, and perhaps at that time there could potentially have been more lymph nodes resected. Whether that's beneficial or not is hard to say in the set of metastatic disease. And also they could have planned to potentially resect the gallbladder as well, which is something that you might touch later or not, I don't know. Just again, the planning of how we do things in anticipation of some of the problems that we might be seeing in the future.
I absolutely agree, and as a surgeon on the panel, I can't tell you, I feel like you're the surgeon on the panel, so this is great. So yes, I agree with you, and that surgery in an emergent setting is always more challenging. It's always more complicated. You obviously have a higher chance of having an issue. Like in this patient actually had a complicated postoperative course, complicated by a wound, dehiscence at a wound infection, ended up staying 3 weeks in a hospital, which we rarely see when we actually do this in an elective manner. So I do think that that's a really very important point that you bring out. And I do think that we should really pay attention to our patients. If the cramping doesn't go away, is the source of the pain related to the mesenteric mass, and is it resectable? So the cramping did actually disappear after surgery in this particular case. So the patient was quite happy. And then finally, she was presented in our multidisciplinary neuroendocrine tumor clinic after all of this was done at an outside hospital. So she came for a second opinion. And actually at the time when she presented, which was another 6 months after surgery, she was complaining again of worsening flushing and diarrhea, despite continuing on the long-acting octreotide. She also had persistent cramping that came back after surgery, a couple of months after surgery, and shortness of breath on exercising. So what now, Dr. Liao? Andy, what do you think?
Yeah, I think these symptoms are suggesting that the carcinoid syndrome might be getting worse. So definitely we want to confirm biochemically, but the shortness of breath on exercise is a little bit worrisome. One of the things that carcinoid syndrome can affect is the tricuspid valve. And so I definitely want to get an echocardiogram to see if that's affected, and start from there. And then restaging the disease also to see if there's disease progression.
Perfect. So we started with the dotatate PET CT, which didn't really show any significant progression of the liver disease. The MRI with EOVIST, which is what we do at our institution quite a bit to determine the lesions in the liver, actually showed quite a bit of disease in the liver that, again, on the dotatate was not that significantly different, but on the MRI compared to the CT actually showed that there were more lesions there, which is, I think, commonly what we see. Thor, do you have any preference to follow these lesions or to follow tumors with MRI versus CT scan when it comes to liver metastases? And maybe Courtney can chime in as well.
So I am actually really warming up to MRI with the EOVIST. So I think There are definitely patients where you can see everything you need to see with just carefully done CT with arterial and venous phase contrast. As long as you're consistent in your methods, I think that's probably what matters more than anything else. We're seeing patients quite frequently who have had the CT scan and an MRI with a different contrast and MRI with EO-based, and comparing all of those, and then a non-contrast enhanced automated PET or SSTR PET. So as long as you're consistent, you just have to find the imaging study that works for that patient.
Yeah, as an imager, I would just add, I think I do agree that the apples to apples is more important than anything else. So whatever you do it the same every time, and ideally at the same institution as well, because every institution does things a little differently as well. Just because it increases the likelihood that we're going to catch slow growth over time if we do it the same way every time. But I would come down a little bit more firmly on MRI with hepatobiliary contrast being far preferable to any other imaging modality. We are taught as people that treat neuroendocrine tumors, we're taught certain ways that these things look on imaging. Oh, they always arterially hyperenhance, and actually it's really some of them do. A lot of them don't. I would say in my experience, probably most of them don't necessarily demonstrate the characteristics that we read about on imaging. The most reproducible way to image these and to catch them regardless, that's not dependent on catching the contrast at exactly the right moment, is going to be this sort of 15 to 20 minute delayed phase on an MRI with hepatobiliary contrast. Now, there are some patients who just can't do MRI, or some, because they're claustrophobic or hate it, or have a pacemaker, or, so it's not a deal breaker to not be able to get an MRI. And again, consistency is more important, but in an ideal world, all my patients would get hepatobiliary phase MRI.
Thank you. Yeah, and I would point out here as well that here you could see also the difference on the T2 sequence between a cyst as well as a tumor. What's brighter here is a cyst, and what's darker is a tumor, which sometimes is not that clear cut on the CT scan as well. So Andy wanted a TTE or TEE. In this case, we just did a TTE, which is essentially an ultrasound of the heart, and it did show that there was a malfunctioning dilated tricuspid annulus with moderate reflux, so not horribly bad, but that could certainly explain some of the shortness of breath. The serotonin, which is an equivalent of the urinary 5-HIA, just as a blood test, was quite high at 1200. And the CT chest and abdomen pelvis also showed a 5-centimeter mass at the root of the mesentery, which was not clearly seen before. So it's a little unclear whether this was progression or not. So we sent the patient to cardiology just to make sure that the tricuspid valve issue was not a major concern. And they actually decided to manage this patient medically without the need for surgical intervention from a cardiologic or a cardiothoracic perspective. So Heloisa, does this serotonin of 1200 worry you? Do you like to get it lower in somebody that has a heart valve problem that's most likely due to the serotonin?
Yeah, correct. The serotonin and the 5-HIA definitely concern me. I typically tend to monitor patients with the 5-HIA just because I feel it's a little bit more reliable in terms of the variations through the day, or through what the patient serotonin can alternate a little bit more. But regardless, this is high, as several times above your normal. So bringing this down will be certainly important to prevent further damage of the tricuspid valve. And then how you bring down, there are several strategies, right, that you can use, and really depends on if you consider the overall disease is progression. There's progression, then I think one of the ways that one could argue to bring it down is with escalating care to something like lutetium 177. If you feel that this is potentially stable disease, you can bring it down quickly with liver embolizations that are very nice in achieving good symptomatic responses on patients. That's another option. And there is some medications that one can use, such as letrostat, that we can use to control carcinoid-induced diarrhea and also bring the serotonin 5-HIA down. So thankfully, we have few strategies that we can use. And I'm surprised that the initial approach was not to go for a surgical intervention for the heart. I would love to learn more about the thought process and how the patient got followed long-term with the cardiothoracic service and
Sure.
cardiology.
So we talked about the different treatment options. I think you just brought them up very nicely. Heloisa, can you comment on IR Bland-Embo for these type of patients? And do you feel like you can get a pretty good symptom control in those patients that are not maybe actively progressing, at least in the liver, but where the tumors seem to be more active at producing serotonin than they were before?
Yeah, absolutely. Thanks, Xavier. And I think Heloisa touched upon one of the advantages of embolization that we sort of advocate for when we see patients is that the results tend to be sort of quick in terms of the response to the therapy. As you mentioned, oftentimes with neuroendocrine, as in this case, the disease tends to be confined to the liver, and the liver is one of the few organs that is very friendly to our bland embolization procedures because it does have two ways that it gets blood. The normal liver getting blood from the portal vein, and usually the tumor getting primarily its blood flow from the arteries. So that facilitates us to be able to go in with a catheter-based approach and place a catheter into the hepatic artery or the arteries that feed the liver and deliver very small microspheres, usually on the order of 100 microns, so very small. And we usually split the procedure up into two. So we'll treat the right side and then wait about a month and do the left side or vice versa. So we do like this approach because, as I mentioned, we do tend to get good response, even if the tumor is not actively growing, but we're doing it for symptomatic relief.
Thank you. Okay, so I'm going to move a little bit quicker here. I am obviously the surgeon presenting the case, so the patient ended up going to the operating room for liver debulking. We did resect an additional piece of small bowel with additional neuroendocrine tumor primaries that were found within that segment. It's not uncommon for patients to have more than one primary tumor, and then a mesenteric mass that was greater than 5 centimeters, not at the root of the mesentery, but a little bit lower down, that we felt would be a problem down the line potentially and cause further obstructions. We also debulked the liver quite extensively. As you can see here, about 58 lesions were either ablated or resected. The post-op serotonin level dropped nicely, like we mostly see with liver debulking. And historically, before ours came around with Bland-Embo, liver debulking was one of the major things that could be done to improve the symptoms in these patients, also before we had long-acting octreotide. So the patient then, because of normalization of the symptoms and the serotonin, was kept off SSA. This is a postoperative scan here. You could see all of these dark lesions are all post-treatment areas, and then you can see this area here at the root of the mesentery. So what now? Anything else you would do? I guess we don't have to debate too long on whether this patient should go back on octreotide or not. I think most people would probably, I think at Mayo and in Heloisa, you would probably keep them on long-acting octreotide. I think it's certainly a valid point. I think in this case, we chose not to because the patient also had preferences not to go back on it for a while. And so we gave that patient a break, which again, we thought was reasonable with a serotonin that had normalized.
Yeah, can I just clarify?
Yes, please,
so
go
all
ahead.
because I said about Lutathera, but then when I was rethinking, so even though some of the lesions on the dotatate were positive, some were less, but were the lesions overall, they consider everything that was positive on imaging, or there was a mismatch?
No, it's a good question. All of it was considered to be positive.
Okay.
Yeah.
Okay.
So she would have been certainly, and you will see, she will get PRT. So about 3 years later, sorry, anything else you want to add?
I was going to say, I generally, if there's that much disease just in a single organ, there's kind of a sweet spot for PRT, and to me, it's when there's more disease outside of the liver. So I'm in agreement with the management.
Thank you. 3 years later, the patient had return of symptoms. Serotonin increased again to 800. What now? This is a repeat MRI, and you can see some disease recurrence, so probably maybe some persistence of some lesions that had grown again. Oz, would this be a good candidate for liver-directed after surgery? Can you actually use liver-directed therapy after surgical debulking?
Yeah, absolutely. I think I've probably touched upon this in other talks. The liver is a very resilient organ, as you've illustrated by that fantastic, surgical resection that you did. And is really the two limitations that we have to doing bland embolization is how is the patient doing from a sort of what we call functional status. So if the patient is active, healthy, able to tolerate daily activities, that's somebody that we can treat, as well as as long as the underlying liver function itself. So we look at the lab values for the liver function, and if those are all within normal limits or acceptable, we can proceed. So even if you've, as you've sort of illustrated, done an extensive surgical operation, we can still offer this patient bland embolization with the same approach that I mentioned before, where we would probably split it up into half and half, so right and left or left and right.
So in this case, we restarted octreotide, which I think we can all agree upon, see if the symptoms improved. And actually, a year later, this patient did undergo bland embo. We also tried Zermello. It didn't seem to particularly improve her symptoms. Thor, what's your take on Zermello? Is there anything in particular you think it's worth starting on all your patients that are symptomatic despite being on octreotide? How long do you usually try it for? And what has been your success rate?
Great question. So the Zermello or telotrestat is a drug that inhibits or reduces the production or synthesis of serotonin. So it's really mostly used for carcinoid syndrome diarrhea, but that's a diarrhea caused by serotonin production. But I will say probably the majority of patients with neuroendocrine tumors and with diarrhea have diarrhea because of something else we did to them, such as small bowel resection. Now they have what's called bile acid diarrhea. Telotrestat is not going to work for that, but if you don't look for it, you're not going to find it, and you might treat patients with a drug that's never going to work. And so I work everyone up for bile acid diarrhea. It's very simple to do. And I also ask very carefully about symptoms of steatorrhea. So that's a diarrhea secondary to the octreotide and lanreotide injections. And you need a totally different approach for that. But once you've sort of zoomed in on those who truly have carcinoid syndrome diarrhea from serotonin productions, the telotrestat or Zermello actually works pretty well. And I think the studies that were done did not carefully exclude patients with other causes of diarrhea. So I do use it for that. But hard to say. It reduces the number of stools a little bit. But some people have a really dramatic, like life-altering response to it. Definitely worth trying for 6 to 8 weeks before you give up.
Yeah, that's a very good point. Don't give up after 2 weeks. You got to try it at least for a month and a half or 2 months. I think it's a really important point you bring up. And your point is very well taken. With the post-surgical diarrhea, that's usually due to bowel reabsorption problems or like pancreatic insufficiency due to lanreotide or sandostatin. So very nice. 1 year later, the patient, like I said, underwent bland embolization. Improvement in the symptoms, pretty dramatic, actually. Nice serotonin drop. Now, 2.5 years later, recurrence of symptoms, serotonin back up again to 850. Andy, we eventually treated this patient with 4 cycles of PRT. Do you think that was, in hindsight, the right treatment at that point? I have to mention here some progression of extrahepatic disease seen on the dolitate at that time as well, which I didn't mention.
Yeah, I think so. I think in the setting of disease progression and also worsening carcinoid syndrome, it seems that we should be dialing up the systemic therapy. So PRT is one of the great options for this.
I think that concludes our first case.
Hello, my name is Thor Halfdanarson. I'm a medical oncologist at Mayo Clinic in Rochester, and I will be presenting the next case, a case of pancreatic neuroendocrine tumor. So this is a gentleman who presented to us with a history of severe abdominal pain and a little bit of a backstory. So he had months of really bad reflux and diarrhea and eventually got severe abdominal pain relatively suddenly, presented to his local emergency room, had the CT that showed free abdominal air. And he had a perforation of the duodenum, so essentially a hole in the duodenum, and underwent emergent surgery that was fixed. And then, obviously, as we talked about before, this was emergent surgery. This was not cancer-directed surgery, so there was no resection or removal of any tumors. So then after this, he had the ongoing evaluation locally, which was all really well done, and had an MRI of the abdomen. And now they see that there's a mass in the pancreas. It's really concerning for a neuroendocrine tumor, at least as per the MRI. So an upper endoscopy with ultrasound was ordered. And there was a mass in the pancreas, and the head of the pancreas was biopsied and was a well-differentiated grade 2 neuroendocrine tumor with a Ki-67 nuclear grade of 12%. At that time, he also had a gastrin level that was fairly elevated. I can't remember the actual number, but was up. So he came to us for another evaluation and had a CT scan, and he had what you see on the right hand there is a blast from the past. This is an octreo scan. So this is in 2016. This is just before we got our SSTR PET scans. So you can see the liver here. You can see this is a mass, either a lymph nodes or a mass in the pancreas, and it lights up really bright. And there were no metastases at that time. This seemed to be limited to the pancreas and was clearly producing this hormone called gastrin. So now the question is, what do we do now? So we have someone who's otherwise pretty healthy, the duodenal perforation, had diarrhea, had elevated gastrin, and maybe we'll start with the surgeon, Dr. Keutgen. So what is going on there? So how do you connect all of these dots?
I'm honored. Thank you for letting me start here. So a couple of things I think of. First of all, if you said the gastrin was above 1,000, it's sort of almost diagnostic for gastrinoma, although you can have occasionally high gastrin levels, when patients are on PPI, but that high is usually pretty diagnostic for gastrinoma. So gastrinoma is a neuroendocrine tumor that produces gastrin, and it can either be found in the duodenum or in the head of the pancreas. Most commonly, these can present with actual ulceration or damaging of the mucosa of the duodenum or the stomach, which can cause perforations, which is probably what he had the first surgery when they went in and they saw free. I don't know exactly what they sewed up and where they saw it, but assuming that it was somewhere in the duodenum or the stomach, that's probably what we're dealing with here. The interesting part on your CT is, and on your Octuvia scan, is that it was hard for me to say whether this was truly part of the pancreas or, as you said, whether this was a lymph node. So I would push my endoscopist to make sure that they essentially evaluated like the entirety of the duodenum, because gastrinomas are often found in the duodenum, and it can be sometimes in the third or fourth portion of the duodenum. And so if they are pretty sure that there's nothing in the stomach in terms of mass or nodularity, and nothing in the entirety of the duodenum, then you could certainly assume that perhaps what you see on the CT is part of the uncinate process of the pancreas and is a neuroendocrine tumor of the pancreas, primarily that came from there. I would say an MRI perhaps is helpful also sometimes in being able to differentiate that. And then one last thing is I would consider certainly checking out whether there's a family history. There are some gastrinomas that are essentially associated with what's called MEN1 syndrome, so primary hyperparathyroidism, as well as pituitary tumors. So if there's no strong family history, then this could be certainly a sporadic gastrinoma, but it is something that we ought to consider. And after all of these things, assuming that things are still localized, I think he buys himself a surgery so we can go resect whatever needs to be resected, whether it's the peripancreatic lymph nodes and the duodenectomy and the duodenal mass, or whether it is the primary mass that's within the uncinate process of the pancreas.
So we got some more imaging, and I think he had another endoscopy, and eventually it was concluded that this was tumor of the uncinate process of the pancreas. It was sort of like exophytic and sort of hanging off the pancreas, and there wasn't really anything obvious in the stomach or duodenum. So he underwent the Whipple resection, so removal of the pancreatic head and part of the duodenum, and there was a well-differentiated NET in the pancreatic head, or the uncinate process actually. And now the KS7 was 23%. It was well-differentiated. 3 of 17 lymph nodes were involved. And this is actually where I got involved. So this is back in 2016. So now the question, this is maybe a good one for the medical oncologist, Dr. Liao and Dr. Soares. So what are we going to do now? So back then, we didn't really have much information. Are we going to observe or give adjuvant chemotherapy, or what's the way forward?
So now I would enroll this patient in the ongoing trial.
Right answer.
So this patient had many high-risk features, the lymph nodes, the high KXC7, the symptoms. So there's actually an adjuvant therapy trial. So adjuvant therapy are treatments to help, reduce the chance of recurrence so people live longer. So there's an adjuvant therapy trial of capecitabine and temozolomide chemotherapy. But 7 years ago, that the trial was not in place. So we'll be curious to see what the patient did.
Well, that's an excellent point. And just want to emphasize that this is really the only way we move the field forward, is that we do trials for particular scenarios like that. We didn't have that information now. We don't have that information now because the trial is ongoing, but maybe this will be effective therapy. So back then, ultimately, it was decided to watch him carefully, and nothing was done other than repeat imaging.
So did the gastrin level normalize?
Yeah, gastrin levels actually came down, didn't normalize completely, but were sort of hanging above the upper limit of normal, about twice the upper limit of normal. Definitely a lot better. And the reflux got a whole lot better. So I think this was like real Zollinger-Ellison syndrome, so overproduction of gastrin. So we follow him, and then a little bit over a year later, he comes in, and here I'm doing the MRI. So even back in 2017, I was sold on MRI. So it's so really following with MRI. And now we can see that there is a small lesion, little dot on the liver here that wasn't really seen previously. And this lymph node that had been there after the surgery, but the smaller, is now getting bigger. So now we have a somatostatin receptor PET-CT. This is prior to us using PET MRI routinely. And we can see that these are just representative shots. And as I think Dr. Lawhn Heath said before, you have to take a look at the whole picture. So the liver probably had about 5 to 10 of these little dots and a few of these lymph nodes back there. So these were presumed to be small liver metastases. We didn't go ahead and biopsy it. We thought we had enough evidence here. So maybe a question for Dr. Ahmed here. So how many is too many for liver-directed therapy?
There's no such thing as too many, in that as long as the patient's underlying or normal liver is functioning well and the patient is doing well, clinically or physically, able to tolerate normal activities, we indiscriminately can do bland embolization, I think, as we've mentioned before. When the question really then, I think, becomes, what's too many to do what we call ablation, where we put the needle in and directly burn the tumors. And in that situation, we tend to not do more than 3 or 4 lesions at a time. Doesn't mean we can't do more, but it becomes very time consuming. So those are sort of the ways that we look at it. If we're looking at more than 3 or 4 lesions, then we lean more towards bland embolization.
Thank you. And another question for Dr. Keutgen here with, if you have a liver with 5 or 10 lesions, and I think you just showed us before that you can easily remove more than that. What about if you have these lymph nodes in what we call the retroperitoneum? Is it still worth going after the liver? Can you get to those lymph nodes?
Yeah, so you can get to them, but it's not always that straightforward. If you have very extensive retroperitoneal lymphadenopathy, most of the time, the appetite to do surgery becomes a lot less because it gets very complex. And there certainly are a lot of really important structures in that area, including, like you see here, the blood supply to the left kidney. But we can certainly do that surgically. It's not that it's not possible. I would say the overall question for this patient is, a year later, do they really want to go through surgery again? I mean, surgically speaking, both of these lesions are resectable. But I would tell the patients that I would rather probably wait a little longer, maybe do something a little bit more systemic, like maybe long-acting octreotide or so, and sort of see how much more it clears itself. Because that lymph node on the left side is sort of an atypical location for a localized disease, right? So it's not just the liver, but it's also away from where the tumor was, which was on the right side of the abdomen. So I would assume that there are more lymph nodes around the chain on the left side and possibly on the right side that are going to show up over time. So I'm not sure I would recommend surgery right now.
Okay, and then there's a question for Dr. Lawhn Heath. So here we have an SSTR or somatostatin receptor PET, and keep in mind that these tumors are crept into the grade 3 range, barely, but still made it. Should we do the other PET, the FDG PET?
Well, that's a great question. So first of all, it's very difficult in our insurance environment in the US to get both a dotatate and an FDG PET approved. Those are looking at 2 different things, right? FDG PET is looking at metabolic activity of the tumors, whereas SSTR PET, like dotatate PET, is looking at to what extent are these tumors expressing functional somatostatin receptors. So theoretically, insurance should be willing to pay for both. They're asking 2 different questions, but it's very difficult. So generally, if I'm making a decision about whether to treat somebody with PRRT, I don't care if you tell me that it's grade 3. I don't care what the Ki-67 is. I mean, I do for, to just figure out how well they're going to do and that kind of thing. But what's the most important by far is the dotatate PET-CT and how avid the tumors are on that. If the only reason that I would recommend an FDG PET-CT in a case like this would be if I saw a finding on the CT or the MRI that looked suspicious, but was not lighting up on the dotatate PET. Then I think we would need further investigation to make sure that that's not a metastasis that has become more dedifferentiated. Otherwise, I just let the dotatate PET or the somatostatin receptor PET stand.
Thank you. And that's pretty much what we did. So back then, we didn't really have much information on adding FDG PET-CT and figured we would not get it approved anyway. So then a question again for Dr. Soares and Dr. Liao. So with the grade 3 tumor, does this mean that we're dealing with a different tumor, or what's this all about?
Great question. And I think there is grade 3s with a Ki-67 of 20 to 30 that behave very aggressive, and there's grade 3s with a Ki-67 of 20 to 30 that tend to behave more as a grade 2 with more indolent. In this particular situation, I will probably give the test of time and start this patient on a somatostatin analog with a very short intervals of scanning, right? In some patients, you can go 6 months without scanning. This is someone that I probably would scan with a cross-sectional imaging every 3 months in the beginning to have a sense. In addition to what was already said about the FDG PET, I probably, in the idea, I wouldn't have done at that time, but if after that I was considering going for the PRT, that's when I would be very interested, if I could, in the ideal world, to get the FDG in addition to repeating the dotatate. So what I would have done here is starting the somatostatin analog with short intervals of scans every 3 months initially and see what happens.
And we did not compare notes before I presented her. So
That's right.
This is exactly what happened. So although back then it was started, long-acting octreotide was started at 20 milligrams, one could argue we should have started at 30, but you can start, that would be the typical tumor controlling dose, and we continued the proton pump therapy for acid suppression, as I didn't tell you that the gastrin levels were starting to creep up, but there were no symptoms. And then we repeated the imaging in 3 months, and there was a slight increase in some of the lesions. So we just bumped up the octreotide dose to 30 milligrams. So in December of 2017, then we do another scan, and I'm not comparing the old scans to the new scans, but now there is some growth of the tumor, and there are some new lesions in the liver that were clearly not there before. So what do we do now? So keep in mind, this is a well-differentiated grade 3 neurotumor of pancreatic origin. New lesions, lymph nodes also getting bigger, and we're starting to see more retroperitoneal lymph nodes a little bit further down.
I guess my prediction was right. More retroperitoneal lymph nodes. Yeah, I'm going to bail out here, surgically speaking. Grade 3, progression of disease on somatostatin. I think if I debulk him, things are going to come back pretty quickly. So I'll take a break.
Dr. Soares and Dr. Liao.
I think that's a perfect patient for us to discuss the current Lawhn trial that compares PRT versus CAPE-10 in patients that had progression on somatostatin analogs or bulky disease of the pancreas. So that will be what I will be discussing with the patient, these two options under a trial.
Okay, so Dr. Ahmed, in terms of progressive liver lesions, if you're starting to see new liver lesions pop up, is it worth trying to ablate the new stuff, or should we do something like drug therapy?
Yeah, I mean, to me personally, I probably would lean against doing something local regional because this doesn't seem like a local progression. In general, I think we tend to apply our therapies, as we talked about, for symptomatic control, but also now in cases where there's only sort of very focal progression in the liver, for example. So I would lean against it probably.
Thank you.
Do we know if those new lesions are dotatate avid, or are they one of the non-avid ones that Courtney was talking about?
Question. At this time, we didn't have that information, but a few months later, we repeated an SSTR PET, and these were all avid. There were no lesions that were not accounted for on the SSTR PET. So this being 2017, we proceeded with CAPE-10, capecitabine and temozolomide, which was very well tolerated. But then a few months later, 6 months later, there was now progression in the liver. So the liver lesions were getting larger, and there were again more liver lesions. So what do we do now? So any thoughts on where, and again, this reflect, also pay attention to the timing of this. This is 2017. So maybe Dr. Lawhn, Heath can tell us a little bit about when did we get PRT in the US?
Well, yeah, so PRT was done for a long time in Europe and Australia prior to it coming to the US. We started doing PRT at UCSF on a clinical trial basis around 2016, but it was not FDA approved until 2018. So this would have been a referral to some kind of clinical trial at that time if PRT were indicated. Although I would want to see a repeat dotatate PET to make sure those mets are avid.
And that was indeed done. I'm not showing that, but that was still Ahmed. So we presented the case at the tumor board, and at that time we didn't have access to where PRT was sort of coming on board, and we were not. The practice was not really up and running yet, and there were progressive and new liver metastases. So we started everolimus. And after 3 or 4 months of everolimus, we did another imaging study, and now I'm showing you a little bit more information. So on the left-hand side, we see the fused dotatate SSTR PET images. It's actually a PET MRI. We see the MRI part just showing one of the lesions, and then we see what's called the MIP. Always forget what that stands for. So sort of a
maximum intensity projection.
That's what it is. And I find these very helpful for patients because you can rotate these, and these are very easy sort of anatomically for both me and the patients to talk about. So now everything is very everything lights up really bright, and there's nothing that doesn't light up. So what are we going to do now? So I think we can all weigh in here.
Can I weigh in first?
2018. Yeah. Yes.
I was going to say, so this is where I would, in my local tumor board, become very annoying and start pushing very hard for PRRT. So there's significant extra hepatic progression, right, as well as a lot of disease in the liver, and most importantly, it's extremely avid. And to me, even if there was a lower burden of disease with this level of intensity of uptake, that's an indication that those tumors are going to take up a lot of radioactivity, and definitely bumps up my willingness and my desire to do PRRT. I would push for PRRT here at this time.
Excellent. But keep in mind, now we've gone through a somatostatin analog, CAPTEM, and everolimus, and things are progressing. And indeed, we proceeded with PRRT. So he received 4 cycles of lutetium-177 dotatate, also known as Lutathera. We continued the somatostatin analogs, and actually we'll get there in a moment. So had a partial response in the liver and lymph nodes with mildly decreased size and a little bit of decreased intensity, although we didn't do a lot of PET early after we completed the PRRT. So February 2020, stable disease. Then we did another PET imaging in September of 2020. So this is now almost 2 years after completing PRRT, and things are actually looking pretty good. So here's a question for probably all of you, but maybe mostly the medical oncologist. So should we continue the octreotide or lanreotide after PRRT? These are not inexpensive drugs.
So I personally do, especially if it was given for symptom reasons, or patients who have hormonal secretion symptoms. In that situation, I definitely continue. Now, if they have a non-functioning tumor and they've technically progressed on octreotide before, you could argue, then what's the point of continuing with that? Toxicity, both physical but also financial.
Yeah, so he had in the past had the syndrome, so we figured, well, in the absence of better data, we should continue the somatostatin analog, and we that's what we did. And then unfortunately, can't show you we didn't have a PET scan from that time, but now there's clearly progression in the liver, multiple new liver lesions, and they're clearly larger. So any thoughts from any of you here? So
what about rebiopsying these lesions and perhaps looking at whether number one, the grade has changed, probably repeating the PET scan, making sure that there's still obviously uptake and they haven't de-differentiated. And then I don't know if you guys routinely use genomic profiling, if that ever changes your treatment sequence, especially when you sort of start slowly running out of options.
Great question. So somewhere along the way, I can't remember exactly when we rebiopsied, and now the Ki-67 was up in the mid-30s. And so with this one, I think we did genomic sequencing. We haven't done a lot of it for well-differentiated grade 3 NETs, and we haven't really found a whole lot when we do it. So we do it for all of the poorly differentiated carcinomas. So that was done, didn't really show much, and we repeated somatostatin receptor PET. Everything still lights up, but now there clearly is progression, but it's not like explosive progression. It's more sort of a gradual progression, and thankfully, not any worsening of his symptoms.
Well, the only thing, I mean, not the only thing, but one of the things that the patient hasn't seen is sunitinib, right? Which could have been used. I mean, I was itching to also considering FOLFOX, but if the overall burden of disease is not super great and we feel that the timeline of progression is acceptable, we can probably hold off on FOLFOX, which is something that sometimes we use when disease is picking up more speed. So on the time, sunitinib, and We also have the cabinet trial that is looking into cabozantinib for patients, and I don't recall on the top of my head, but I think the grade is not necessarily, as long as the tumors are well differentiated, cabozantinib can be considered as part of a trial as well.
And you did spot on. So
okay, and we didn't exchange notes. All right.
No, so that we had Cabo, the cabinet trial open at the time, and you're absolutely right that there is no, all grades are allowed as long as they're well differentiated. So having KS7 of 35 was not a contraindication. It's a randomized trial, 2-to-1 randomization. So 1/3 of patients get placebo, 2/3 get the Cabo, and there was progression shortly after starting. Probably about 3 months, which should probably was in late May. So we unblinded, that is, we looked under the hood, see what he was on, and he was on placebo. So we switched over to cabozantinib. Then he started having worsening symptoms. I'm going to fast forward to the next scan. That was that. So now with the worsening, rising gastrin levels, a little bit worsening of syndrome, but not to the point of the really bad reflux he had before. And just to remind you, this is the PET that I showed you before. So all of a sudden, the liver remains very similar, I'd say, but this explosive sort of growth in the bones. So it's for Dr. Lawhn, is this something we see sometimes? And what are we? And this is a dotatate PET, so it's not like a metabolic PET.
Right. Yeah. So this is not common, but it is something that we can see sometimes after PRRT. And again, I don't know if it's coincidental or not. Would the disease have blown up like this regardless? But it is something that we see once in a while, and it's certainly very challenging. You know, one thing I would say is that, as you said, Thor, the disease in the liver, and from what I can see on the MIP, the retroperitoneal nodes look pretty stable potentially. So it, like as if PRRT sort of did its job on the tumors that existed at the time. But yeah, I'm not able to explain, you know, why this does sometimes happen in the sort of explosion in the bones.
Have seen a few of these before, and that after PRRT. So I don't know, maybe an idea for a research study. So just to the last slide here. So we tried PRRT again because this lit up so bright. So 2 cycles of regular PRRT with lutetium, and there was no response whatsoever. So in May of 2022, we started FOLFOX, so which is a colon cancer-like chemotherapy. There was mild improvement, and he received 5 cycles, and then there was a neuropathy and side effects. So we said, we're just going to stop here. And oddly, that was at the end of 2022, and he has had stable disease since. So I think he must be coming in the next few weeks for scans. But that's sort of his story. Just goes to show that this has been going on for a number of years. And we do have a lot of different treatment options for systemic therapy. So sort of to close this case, if he comes in for progressive disease, any thoughts on what we could do from here? Maybe a question on alpha particle therapy. Do we have that? When are we going to have that?
It's a great question. And so if you had not told me the patient had been retreated with lutetium PRRT and didn't respond, I would definitely have said alpha PRRT would be an option, because alpha PRRT, so it's the same compound, it's still dotatate, still goes to the same receptors. It's just using a different kind of radiation. Instead of a beta particle, which is what Lutathera uses, it's using an alpha particle, which is a more massive particle that does more damage, but also doesn't travel as far. So there's a thought and some preliminary data outside the US suggesting that there might be more effect against the tumors and less off-target effects against things like bone marrow that we want to protect. So it's very exciting. It's something that's just starting to come online in multi-centered clinical trials throughout the country. We're getting ready to open as one site of one type of alpha PRRT any day now, and we're very excited about that. A lot of centers are opening for that. But there are some general requirements for access to most, but not all, of the alpha PRRT trials right now, and that is that you have to have had stable disease for at least 6 months after PRRT.
Well, that takes us to the end of my case.